Welcome to COVID-19, What Pharmacists Know Now, Coagulopathy in COVID-19. This is an installment of a series brought to you by the Canadian Society of Hospital Pharmacists, British Columbia branch. My name is Celia Culley, and I'm a clinical pharmacy specialist in coronary care at the Royal Jubilee Hospital in Victoria, British Columbia, Canada. It's important to acknowledge that research about COVID-19 is rapidly evolving, and we will continue to learn more in the coming weeks and months. The information presented is current as of April 27, 2020. The views in this presentation are my own and do not reflect those of CSHP-BC. A number of hemostatic and inflammatory changes have been observed in cases of COVID-19. These are thought to contribute to a hypercoagulable state. These changes, along with other risk factors in hospitalized patients, such as immobilization, secondary infections, ICU admission, mechanical ventilation, can increase the risk of venous and arterial thrombosis. The optimal antithrombotic regimen for patients with COVID-19, especially those with severe disease, remains uncertain and is currently an area of research. In this presentation, I will summarize what is known so far about COVID-19 and coagulopathy, including the published incidence of thrombosis. I'll review the evidence for thromboprophylaxis in COVID-19, including dosing, and provide some evidence-informed recommendations on the use, dose, and duration of thromboprophylaxis in COVID-19 patients. A number of hematologic lab abnormalities have been observed in COVID-19 patients. The most common ones relate to an elevated D-dimer, an elevated fibrinogen, but may be low in late stages of disease, prolonged prothrombin time, thrombocytopenia, although it is typically mild, and lymphopenia. COVID-19 patients do sometimes share lab abnormalities that are similar to disseminated intravascular coagulation, or DIC. Earlier in the pandemic, we were somewhat limited with the information that was available regarding a hypercoagulable state in COVID-19. There were anecdotes on social media, case reports, and case series describing an increased risk of venous thromboembolism as well as arterial thrombosis. What was published initially related to VTE risk that was elevated in the absence of any pharmacologic prophylaxis, including one study that reported a 25% risk of a lower extremity DVT in 81 ICU COVID-19 patients. Keep in mind, this was without any pharmacologic prophylaxis. Autopsy data was also published reporting pulmonary microthrombi in patients with COVID-19 acute respiratory distress syndrome, or ARDS. However, microthrombi is in keeping with ARDS pathophysiology, and so it's difficult to determine if this was related to COVID-19 or ARDS itself. As the pandemic has progressed, there have been more studies published on this topic. This study was a retrospective cohort study out of Italy that looked at nearly 400 hospitalized patients with COVID-19, 16% of which were in the ICU. VTE prophylaxis was given to 100% of patients in the ICU and 75% of patients on the general ward. The regimens varied significantly from, as I mentioned, no prophylaxis, ranging to prophylaxis, intermediate dose, and therapeutic dose anticoagulation. The rate of clinically significant thrombosis in the entire population was 8%. About 3% of which were pulmonary embolism and 2.5% were ischemic strokes. So as you can see, there were both venous and arterial strokes identified. The rates of thrombosis were higher in ICU patients at 17%. Of note, there were no bleeding complications found in this study. This was a prospective cohort study looking at 2 centers in France of 150 patients in the ICU with COVID-19 ARDS. 78% of patients received prophylactic heparin or low molecular weight heparin, whereas 22% received therapeutic anticoagulation. 67% of patients were still intubated at the time of analysis. Therefore, incidence of thrombosis may have been underestimated. At the time of analysis, 27 of 150 patients had experienced some form of clinically significant thrombosis. 25 of those 27 experienced pulmonary embolism, but there was a range of other types of thrombosis, including deep vein thrombosis, stroke, limb ischemia, and mesenteric ischemia. 97% of patients requiring continuous renal replacement therapy experienced circuit clotting, and 2 out of 12 patients receiving ECMO had thrombotic occlusions. Only 4 of the 150 patients experienced hemorrhagic complications. This study had an interesting finding when they did a matching analysis of non-COVID versus COVID ARDS. As previously mentioned, ARDS pathophysiology does increase the risk of pulmonary microthrombi. But when they did this matching analysis, there was a higher rate of thrombosis in the COVID ARDS patients with 12% risk of thrombosis compared to 5% in the non-COVID ARDS, signaling that COVID patients are at higher risk of thrombotic complications compared to non-COVID ICU ARDS patients. This study provides further guidance regarding thrombosis risk in COVID-19 patients admitted to the ICU versus those admitted to a medical ward. In ICU patients, the rate of symptomatic VTE was 23% versus 3.2% of COVID-19 patients admitted to a medical ward. For pulmonary embolism, specifically, the risk was 12% in ICU versus 1.6% on the medical ward. Of note, at the time of data collection, almost 30% of patients were still hospitalized, so the incidence could be underestimated. The bottom line is that COVID-19 patients appear to be at higher risk for thrombosis. The exact incidence of thrombosis is unknown, but it appears that critically ill patients are likely higher risk than those on a medical ward, and that patients with COVID-19 are likely higher risk than those hospitalized for other reasons. There's risk of both venous and arterial thrombosis, and at this time, the mechanism is not known. It seems logical that we should be using pharmacologic prophylaxis in these patients. However, we do need some evidence to support that practice, and that evidence does exist. Of 449 patients admitted to a single center in Wuhan, China with severe COVID-19, only 22% of patients received VTE prophylaxis. Most of those patients received enoxaparin 40 to 60 milligrams sub-Q daily. There was no difference seen in mortality overall between those receiving prophylaxis versus no prophylaxis. But when certain subgroups were assessed, there was a reduction in mortality. The 2 groups that had significant reduction in mortality were patients with a 6 score or sepsis-induced coagulopathy of at least 4, and those with a D-dimer at least 6 times the upper limit of normal. In terms of what a 6 score is, the 6 score stands for sepsis-induced coagulopathy and identifies patients at an earlier phase of sepsis-associated DIC, which basically signals these patients may be at higher risk of thrombosis. So one thing we can be fairly sure of is that we should be using pharmacologic prophylaxis in COVID-19 patients admitted to hospital. This is in keeping with the Public Health Agency of Canada recommendations that for adults and adolescents admitted to hospital with COVID-19, they should receive pharmacologic prophylaxis with low molecular weight heparin being the preferred option. Unfortunately, no dose is provided. So what dose should we be using in these patients? Unfortunately, we don't have any good studies to answer this question, but I'll present what we have so far. This is a study looking at 3 Dutch hospitals of 184 ICU COVID-19 patients. The 3 different hospitals used 3 different regimens of nadroparin, and also partway through, 2 of the hospitals changed their protocol from a standard dose to intermediate dose nadroparin. The cumulative incidence of thrombosis was 31%, with pulmonary embolism being the most frequent thrombotic complication. Unfortunately, the authors don't provide any specific analysis stratifying by the different dosing, but we're hoping that that study will be published at some point. Given that we don't have good evidence to guide us at this point, what dose should we use for thromboprophylaxis? The BC Centre for Disease Control does provide recommendations regarding a number of different therapeutics for COVID-19, including recommendations for VTE prophylaxis. They suggest an intermediate dose of enoxaparin of 30 milligrams sub-Q twice a day, and they suggest even higher doses of enoxaparin for hospitalized patients with a weight above 100 kilos or a body mass index above 40 kilograms per meter squared. Thrombosis Canada has been hosting webinars on this topic, the most recent being April 23rd. They recommend that all admitted COVID-positive patients should receive standard weight-adjusted VTE prophylaxis and qualify that there are insufficient data at this time to recommend intensified empiric prophylaxis regimens outside of clinical trials. The International Society on Thrombosis and Hemostasis, or ISTH, has also been hosting webinars. Their most recent was on April 27th, where they recommended that all COVID-19 patients receive prophylaxis and that you could consider double dose in ICU patients. The American College of Cardiology published a guidance paper on April 22nd that was endorsed by the ISTH, where they state that the optimal dosing is unknown and warrants further prospective investigation. The majority of the panel recommend prophylactic anticoagulation, but a minority suggests that intermediate or even therapeutic dose could be reasonable. The American Society of Hematology, or ASH, also provide a guidance document that suggests that all hospitalized patients with COVID-19 should receive pharmacologic thromboprophylaxis with low molecular weight heparin or fondaparinux. Dose adjustment for obesity may be used as well. ASH acknowledges that institutions are already using intermediate and empiric therapeutic anticoagulation strategies, despite the lack of evidence. They recommend involvement in studies measuring patient outcomes when these studies become available. You may have noticed, like I did, that ASH recommended low molecular weight heparin or fondaparinux for thromboprophylaxis in COVID-19. It got me wondering, which agent should we use? So based on what we know right now, low molecular weight heparin has the most evidence behind it. In terms of unfractionated heparin, there's been anecdotal reports of heparin resistance in COVID-19, possibly related to the significant amounts of circulating acute phase reactants that could bind and inactivate heparin. This is just a theory right now, and nothing has been published specifically. In terms of DOACs and fondaparinux, there's been no published data so far for this indication. Low molecular weight heparin does have the most evidence behind it, and there may also be anti-inflammatory effects of low molecular weight heparin in this population. Of course, you would need to balance patient-specific factors in terms of thrombosis risk and bleed risk in patients such as those with renal dysfunction. If you do use low molecular weight heparin in patients with renal dysfunction, you could consider monitoring anti-10A levels in this patient population. All hospitalized COVID-19 patients require thromboprophylaxis unless contraindications exist. Low molecular weight heparin would be the preferred agent. In terms of dosing, based on what we know so far, weight-adjusted standard thromboprophylaxis dosing is recommended. There is limited evidence for intermediate dosing at this time. However, given the higher rates of thrombosis, particularly in ICU patients, it may be reasonable. However, ideally, if we're using these higher doses, we're measuring benefit versus risk by participating in a study. There may be some scenarios where the risks of pharmacologic prophylaxis outweigh the potential benefit. This is based on expert opinion only. However, if patients are actively bleeding, have a platelet count of less than 25 or fibrinogen less than 0.5, you may choose to use mechanical thromboprophylaxis instead of pharmacologic prophylaxis. What about extending thromboprophylaxis in patients with COVID-19 post-discharge? There's no data specific to COVID-19, but there are some experts recommending extended prophylaxis for patients with particularly high risk post-discharge. This is extrapolated data from other populations. It may be reasonable based on patient-specific factors, but we have no specific evidence to guide us at this time. What about stratifying dosing by D-dimer? You may have seen some protocols circulating suggesting higher doses based on baseline D-dimer rates. So what evidence do we have to guide us in this regard? What we know so far is that elevated D-dimer at hospital admission is associated with a poor prognosis. Specifically, one study found that a D-dimer of greater than 1 micrograms per mil on admission was associated with an increased odds ratio of 18.42 for in-hospital death. Unfortunately, D-dimer is a non-specific acute phase reactant and has been shown to be elevated to similar levels in COVID-19 compared to other causes of critical illness. So although we know D-dimer is prognostic for mortality and poor outcomes, there are no studies yet stratifying thromboprophylaxis dosing based on D-dimer thresholds. One study out of Wuhan, China found that a D-dimer cutoff of 1.5 micrograms per mil was potentially helpful in predicting VTE events in severe COVID-19, but as I mentioned, we don't have any dose stratifying studies yet. You may have seen hospital protocols circulating on social media advocating for empiric therapeutic anticoagulation in patients admitted to hospital or specifically ICU with COVID-19. At this time, there's a variation in practice ranging from standard of care, which would be therapeutic anticoagulation only for patients with overt VTE or high clinical suspicion for VTE, or some other reason for therapeutic anticoagulation. But there are other sites starting therapeutic anticoagulation for all ICU patients admitted with COVID-19. At this time, there's no evidence to support or refute this practice, but there are studies coming to try to help answer this question. There's also a theory regarding using empiric thrombolysis in patients with COVID-19, specifically ARDS, but at this time only case series have been published and there's insufficient evidence to recommend the widespread use of this therapy. As with other aspects of COVID-19, there are still several questions to be answered related to coagulopathy and COVID-19. There are some studies coming that I'm excited about, and there are two looking specifically at different dosing thresholds for anticoagulation in COVID-19. One of them includes different dosing based on D-dimer thresholds. So that's the Improved COVID RCT and the Rapid COVID Coag study. So those two are hopefully coming, but will likely not be published for a while. There's also questions regarding the potential benefit for thrombolysis or low-dose thrombolysis. There are no studies pending at this time. There is one study planned looking at risk versus benefit of thromboprophylaxis in outpatients with COVID-19. We still don't know the optimal duration of prophylaxis in COVID-19, and there are at least a couple studies pending related to looking at different antithrombotic therapies compared to low molecular weight heparin for thromboprophylaxis in COVID-19. There are limitations to the existing data surrounding coagulopathy and COVID-19. Much of the data is retrospective, not peer-reviewed, and often patients are still in hospital or even intubated at the time of data analysis. From what we do know, though, it does appear that severe COVID-19 infection increases the risk of thrombosis, likely greater than the risk of those admitted to hospital or ICU for other reasons. It also appears that COVID-19 patients admitted to ICU are likely higher risk of thrombosis than COVID-19 patients admitted to a medical ward. COVID-19 shares similar lab abnormalities as disseminated intravascular coagulation. We know with typical DIC, we would treat the underlying cause, which would hopefully help reduce the risk of thrombosis in these patients. Unfortunately, with COVID-19, we're limited with the therapeutic options available to treat the disease. Coagulopathy in COVID-19 could progress to DIC, especially if there are secondary complications. In terms of how to manage these patients, based on what we know so far, the recommendation would be weight-adjusted standard thromboprophylaxis with low molecular weight heparin in all COVID-19 patients. There may be some benefit for intermediate dose or possibly even therapeutic dose in ICU COVID-19 patients. However, we have very limited evidence to guide that practice at this time, but there are forthcoming guidelines to hopefully guide us whether the benefits outweigh the risks of different regimens. Thank you for attending this installment of COVID-19, What Pharmacists Know Now. This series has been brought to you by the Canadian Society of Hospital Pharmacists BC branch.